Good afternoon, everybody. I'm Sunny Danani from Ottawa, and I'm very humbled to moderate the next session, which is a panel discussion. And we're going to work from actually the last two talks and talk more about the determination of death, in particular some cases around toxicology to start. So I think you'll find this very interesting. Maybe what I'll do is start by inviting our panelists. David Greer, you met earlier already, a clinician and expert scholar in brain death from Boston. Margaret Thompson is maybe not here yet, so we'll wait unless she steps up. Oh, there she is. Fantastic. She's an eMERGE doc at St. Mike's, brilliant toxicologist and director of poison control here in Ontario. So we're very thankful to have her. Jeff Singh is a neurocritical care physician here in Toronto, also a regional medical lead for Trillium Gift of Life for donation. And Matt Weiss, who's the chief medical officer for Transplant Quebec, and a colleague of mine as a pediatric intensivist, so highly respected. Andrew Healy, chief medical officer for Trillium Gift of Life, and who we all work closely with here. So what we're going to do is ask a question, present a case, ask a question to you guys, and then ask one of our panelists to answer. So the first question is very similar to one of the cases that was presented, but we thought we'd give you an opportunity to answer it. A 22-year-old male at a party took multiple substances at the scene, and these were noted by bystanders. It wasn't in his pocket. Found unconscious and apneic. Out of hospital arrest was prolonged, and return of circulation was at 36 minutes once in the ED. Now ventilated in the ICU. The pupils are documented at 5 and fixed. Was put on a cooling protocol at 34, however, not fully cold, and no sedation was needed. Urine dip is or screen is cocaine and ecstasy. CT shows swelling, loss of gray white differentiation, but no clear herniation on the brainstem. And so we're at 24 hours now, and appears declarable. What would you do? So what I'll do is maybe start with Margaret, since this is related to toxicology. You got your slide back on there. Is maybe some general comments, but maybe you could think about, should everyone get an ancillary test in these cases because of the drugs on board, and does the effect of therapeutic hypothermia change that answer? Margaret.
I'm not sure, is my mic on?
Yeah, it is, yeah.
So just to start, you might look at the difference between what it was reported that this gentleman took, crystal meth, heroin, fentanyl, purple haze, et cetera, at the scene, and what was found on his urine drug screen, being positive for cocaine and ecstasy, none of which was reported that he'd actually taken. It is unusual for cocaine and ecstasy to cause instant death and to, inject and then to drop, like it might happen with the opioids, as they rush to the brain and cause respiratory depression. And sometimes we find these patients with a needle in their arm that they've injected and died. I'm not a transplant physician, so I'm not going to try and talk about the neurological determination of death. But that then speaks to the utility of a drug screen as a ancillary test that might make you better informed about whether this patient should be eligible for the criteria for neurological determination of death. When I believe one of the criteria is that no active substances should be on board. So from my point of view, just to give you a better perspective, is that most drug screens done in emergency departments and then done in ICUs and such are point of care tests which depend upon an antigen-antibody reaction. And so most of them are not very specific, and some of them are not particularly sensitive for many of the drugs that people are using on the streets. And I practice in Ontario and Manitoba, and in our centers we use a point of care drug screen that will not test for fentanyl, So it's not there because we're not testing for it. And so you don't know for sure what drugs are involved because we just don't have the capacity to test for thousands of different chemicals that are out there on the streets. There are many, many fentanyl analogs. We do have a point-of-care test in Ontario now that we can purchase separately from our, usual drug screen that will detect positive or negative up to 10 different fentanyl analogs, including baseline fentanyl. It does include carfentanil and a number of other remifentanil, sufentanil, et cetera. But it's a generic everything is there or everything was there. So if the patient took the drug, it's gotten to the urine, it could still be positive in the urine for days after the last use of that substance. It's particularly, not just the fentanyl test, but the other point-of-care tests are particularly bad for things like cocaine and cannabinoids because they detect the metabolite of those drugs as compared to the parent of those drugs. And it's probable that the metabolite is not active. The other specific thing about the point-of-care testing is that the antibody is made against a particular part of a chemical. And so the antibody for opioids is cocaine, or is codeine, and if your drug doesn't look like codeine, then it's not going to show up as being positive for codeine. So we miss a lot of things, and we overcall a lot of things because of the peculiarities of an antibody-antigen drug screening test.
Fantastic insights. David, now taking that, what would you do when it comes to declaration?
Well, I think one of the general principles is if you're in doubt about the potential reversibility of the situation, you don't declare, and you should not be in a rush at all. There was some data probably about 10 years ago suggesting that if there's a delay between the two examinations that organ donation rates went down. But as I said in the earlier section, there's far more danger in inaccurately diagnosing somebody brain dead. We have to be right about this. I think there are flaws, certainly trying to do the clinical exam here, but also you could think that there would be flaws in trusting an ancillary test as well. And it kind of depends on what ancillary test that you get and when. So I guess there are so many confounders right now, the hypothermia, the age of the patient, the drug intoxication, the whole thing makes me feel very, very uncomfortable. And so I would let the dust settle. Probably one of the most helpful things that I use from a practical standpoint is a neuroimaging study, particularly a CAT scan that shows herniation. That you can't fake, and there can't be false positives. MRI you have to be a little bit careful with in these situations, but if you have a CAT scan that shows a completely hypodense brain that's herniating, then you can perhaps start trusting your ancillary tests a little bit more. But you really want to be certain in these circumstances and err on the side of caution and not declaring.
Very thoughtful. Okay, Matt?
I have actually just a quick follow-up question for Margaret, and also before that, for people who have less fun weekends, apparently, what is Purple H?
Yeah.
Purple haze?
Okay.
It's usually a cannabinoid
Okay.
derivative.
Okay. And then, listening to Sean's talk earlier, I was struck with how far out after the original intoxication there was some apparent return of function. And with all these different analogs on the street, is there any amount of time that you as a toxicologist would say, we've waited long enough, or is, if in this kind of situation where there's a inconsistent presentation between the tox screen and the clinical presentation, if we wait 5 days, 7 days, 8 days, is there any amount of time, or is an ancillary test always going to be needed here?
For the most part, when people are injecting drugs, they have a single bolus of drug that should follow, even their overdose amounts, or it's a naive patient who's never used opioids before, for example. They have a single bolus of drug which is, reaches the liver, the kidney, et cetera, in a routine way and should follow normal pharmacokinetics. The patients who take the drug by mouth, and then potentially have a bolus of drugs sitting in their GI tract for absorption for a prolonged length of time because we're not absorbing well, because we're hypotensive, for example, those patients would be far more reluctant to declare without ancillary testing and being sure the drug was gone, et cetera.
Interesting. Good question. Okay, another case. How and when to declare with sedatives in the context of liver and renal dysfunction. So 48-year-old, out of hospital STEMI and VFib arrest, return of circulation at 31 minutes, went to the cath lab, CT head at 4 hours, shows the same as the last one, no loss of gray-white differentiation, no herniation. And now we're 24 hours where there's mild renal dysfunction, liver dysfunction, urine output's borderline. Initially sedated with propofol and fentanyl and with midazolam, and appears declarable now. And all the drugs that were ICU drugs are off for the last 4 hours. Maybe I'll put this question back to Margaret again. Are there certain drugs that we use in the ICU, Margaret, midazolam, for example, that we might have more of a problem with this clearance?
So in this particular case, midazolam with 2 hours is probably an insignificant amount to worry about that's influencing once you've left it for that magical 5 half-lives. Certainly there are things that will decrease the metabolism or the clearance of midazolam. So first, midazolam is metabolized to 2 active intermediates that are then excreted by the kidneys. So metabolized in the liver. So if you're not perfusing the liver well because of hypotension, then it may be an increased time for that midazolam to becoming metabolized, but then it's metabolized to an active drug, which causes sedation as well, and its elimination is dependent on renal flow. And so if your kidneys aren't working well, then you're not excreting your midazolam. So the half-life, or the time to when we eliminate all of our midazolam, can be hours, days longer than it would be if it was a normal 1 to 2 milligram dose for my eMERGE patient to keep them quiet in the psychiatry area.
Right.
So the prolonged infusions of midazolam on a sick patient will definitely require more than the typical 5 half-lives. One of the things that I have seen in the literature, because we can't get drug levels of midazolam, in an easy fashion. Certainly you're able to get it for research studies, et cetera, and the metabolites as well. But because we can't get those easily to help guide the clinician at the bedside, there is some literature that suggests using very low dose reversal agent, flumazenil, for the benzodiazepines might be safe and might give you an indication as to whether the depressed level of consciousness and the depressed respirations are because of the drug itself or maybe because of the neurological injury. The manufacturer suggests 0.3 milligrams as the dose of midazolam to use for reversal of benzodiazepines. Generally, as toxicologists, we say don't do that. But because we don't want to precipitate status epilepticus and acute withdrawal symptoms, tiny doses, 0.05 milligrams, 0.1 milligrams, might be adequate and not dangerous to that patient and might give you the answer that you're looking for.
Wonderful. Jeff, any comments on that?
Maybe just before American asked, so similar to kind of the, I think Ian Ball had the question about the naloxone in the previous session. If you don't see, I guess it comes down to certainty, like if you don't see a response to, let's say if you get 0.3 or 0.5 of flumazenil, can you be assured that then it's not, like I guess what we always struggle with these cases is you're always looking for, like you're trying to assemble a global, like, I guess maybe not certainty, but feel certain enough, as it were, that that the drugs are an issue.
So I guess you've got to take your patient, your sedation patient, and say, have I had him on for a couple of hours or have I had him for a couple of days? And so therefore, is there a chance for it to accumulate? Has he been hypothermic? Because that will decrease the metabolism of it as well. Are they elderly? Are they obese? These are cases, where you expect that the midazolam might accumulate. Have they been hypotensive for most of that time? So that would be the patient where I would test them with flumazenil, low doses, and work up to that therapeutic dose. And then if you had to use ancillary testing or make that declaration of brain death, it probably is safe
Right.
in most cases.
That's great. I guess wearing my donation support physician hat, my comments might be this, is that I, and similar to Dr. Greer, I would tend to wait, and my advice is normally like, what's the rush? Let's just wait and see. And I recognize sometimes the pushback I get is, well, how long do I have to wait if I'm really worried about the drug? And I kind of where I say, well, like as time goes on, I feel more and more certain, but also I also look for other ancillary, not testing, but other ancillary evidence that supports donation. So let's say if we were to wait another 24 or 36 hours and then we had a CT showing like frank, sort of hypodensity with tonsillar herniation, I feel much, again, more certain, so I proceed that way because I think it's easy to get, I sometimes get caught on the phone calls and these kind of metaphysical or philosophical arguments about, well, if you don't see something, how can you prove that it's not there? And I personally find it clinically that's very difficult, so I try to assemble enough ancillary data that supports this, and then I feel comfortable enough that whether it be with either a flumazenil or naloxone challenge or anything else that that the clinical declaration stands. I will certainly support ancillary testing after we wait, but the challenge with ancillary testing is without a standard, especially with the ubiquitousness of CTA now, and the lack of a clear reporting standard. The CTAs often generate more questions or problems than they do answers or, I think, certainty. So that might be my only. There's a lot to unpack there, but those would be my comments.
And you're giving
about
away
this
the
case.
answer to the next question.
Oh, sorry. Did I steal your thunder? Oh, dude.
Excellent job, actually. That was very thoughtful. Okay, here's another case. Just stepping along Jeff's line. Perfect.
Sorry.
Do you need the clinical exam after the angio? So we've got a 50-year-old man in a traffic accident, traumatic brain injury, CT, and 4-vessel angio show no flow. This was done actually right away before full assessment and the formal prior NDD exam, actually. So 6 hours later, after the angio, they know there's no flow. One clinician comes in and does the brain death exam. Death is determined and signed by the single intensivist, and the radiologist who performed the angio signed the second one. This is a real case.
Well, so yeah, we've had situations similar to this, and obviously everyone here in the audience read the guidelines and understands that the Canadian recommendations are for 2 clinical exams, and that would be the baseline requirement. Now, and I don't think so. And Andrew, you would agree on that there would be the baseline intention is 2 clinical exams. So from a medical director of an ODO perspective, I think we would have to recommend, to fit the letter of the law, the guidelines are clear, the recommendations are clear, we want 2 clinical exams. But this was discussed among our hospital or our donor physicians lately because, while those are the guidelines, the basis of the medical rationale behind those guidelines is a little less certain. I think the same paper that David mentioned earlier, from 2011 in New York, where they had 100 cases, and they looked at were there any reversals of the brain death determination between the first and second examination, and none of them were reversed. And those are in many patients who didn't have a 4-vessel angio that showed no flow. So the comments that I received from the center where this occurred was like, yeah, sure, that's what the guidelines say, but why? What is that based on? And do we really need this here? And so I guess what would you respond to?
Maybe I'll ask Andrew just to add to that answer is, do you think we'll ever move to a radiologically based diagnosis?
Ever? I don't know if I can answer ever, but
Near future.
Not
Near
soon.
future. Near future.
Yeah. So I mean, I guess the first thing I would reflect back on is having recently been on the stand for a while talking about this particular topic, I was pretty reassured that people had done the things that were in the guidelines, and so that's a pretty easy answer to why. The second issue is that the guidelines actually are pretty specific in Canada. They say 2 physicians with expertise in caring for critically ill brain-injured patients and who have performed NDD. To be fair, you really only need 1 intensivist unless it's for donation. So, I think if we're going for a donation, you need a second person who's skilled at that. And I think a lot of people are moving towards using 2 physicians anyway, because as David reflected in his talk earlier, this is a situation where you are really required to be exquisitely accurate in your diagnosis, and we cannot accept error. And so I think whether you look at 100 cases where there's no reversal or not, that's not enough for me to move away from what I think is, if it's best practice for organ donation, why wouldn't you apply it in the setting where organ donation is not going to be on the table? The only rationale you could give for that is convenience, and I just don't buy that.
Logical. Good.
Can I make one more comment?
Yeah, please, David.
Actually, 2 more comments now that I got the mic.
Yes.
CTA is different from conventional angiogram. And be careful, because people want to use CTA, but it is not valid. There have been false positives published, so please be very careful with that. The second point is, as we're trying to do the combined guidelines with adult and peds in the US, we're moving back to 2 examinations because it will make everybody feel better. Our feeling when we did the original guidelines in 2010 was that if one person is fully competent to do it, you don't typically require 2 people diagnosing most medical illnesses. However, the pediatric people are completely uncomfortable with there not being 2 examinations, and so we will be moving back towards recommending 2 for everyone.
Can I ask one more question about imaging? We've talked a little bit about herniation being reassuring. Maybe it's a question for you. I appreciate the anatomical and physiologic, the flow, structural reassurances that gives you. And I internally am a bit reassured by that. But are we aware of any data that suggests that should reassure us in terms of moving forward with clinical examination without a flow study? If you thought you needed a flow study, you did a CT and you saw herniation, then you don't move to flow study because you just saw herniation, that's enough for you? I don't know.
I think it'd be a pretty good study to do, and might be very easy to do retrospectively even, to look at patients who've had a CAT scan that was consistent with cerebral circulatory arrest, and then see did they get ancillary tests, and even look at their clinical exams. It's worthwhile doing, and we could all probably pool our cases together and do it.
I'll make a pitch for Dr. Chasset from Quebec.
Another project from Macau.
He's in the back there. But he is looking at imaging techniques and the declaration of neurologic death. So I think over the next couple of years that we will have more and more information on that. So here we've got a 20-year-old suspected murder. Gunshot wound through the right side of the brain. Was apneic, and pupils were already dilated. Global edema, and there's a bullet lodged in the posterior skull. Actually arrested in emerge. The exam noted earlier was before that for 20 minutes before return of circulation. And now patient appears clinically declarable at 8 hours. Standard of practice is that we wait 24 hours after an arrest. David, do you want to comment on this first? What would you do?
Don't you think you're picking on the U.S. guy a little bit much?
Yeah. Everyone's getting their turn.
I think you've got 2 problems here. First of all, it's a gunshot wound to the head, and I don't trust your examination yet that there could be confounding of the cranial nerve examination. There usually is, with a lot of facial swelling, orbital swelling, so that you couldn't actually trust a clinical exam at all. So that's why I answered number 4, to have an ancillary test regardless in this case, assuming that there is problems with facial edema, which there must be. That being said, I would never just go straight to an ancillary test. I want to make sure that whatever I could do on the clinical exam must be completely compatible with brain death,
right.
And then I would combine the 2.
Lovely. Jeff, any other thoughts to that? It's hard to disagree. That was pretty convincing.
Yeah, no, I concur, and I would still wait, but I agree, I would complete as much of the exams as I could, and for similar reasons would.
Now, do
We've
you
had a
think
similar
sometimes
case
what
to
you...
this- We've had a similar case to this where the cranial nerves were accessible. So, I don't know, does that change your answer?
What if the bedside team is really pushing you and saying, "Why are we waiting?" I'm sure in fact, this was the case I remember. I've done this for 30 years, Sonny. I taught you how to do this, right? Why would I wait? I'm sure he was declarable. I just didn't do it when he walked in the door. The arrest was secondary to herniation. Would I fight it, Jeff?
So sorry, just to clarify, the question is.
You'd push back. You'd stick to your guns.
I would still stick to my gun. Again, it has to do with the one, I guess, what the rush is, like, certainly we don't want to support people who are dead, and I totally, I'm sort of a flag bearer for that. But at the same time, I think the situation is obviously so delicate and fraught with, the risk that we as Andrew said, we can't accept any error, we can't accept being wrong. So, look, if you approach the family, give them a dismal prognosis, and wait expecting to see how things evolve, again, there's always the issues with the ancillary testing, then certainly you give the family a bit of time, you increase your certainty, even if on the basis of, like, look, we wanted to proceed with this because we're worried about stability in organ donation. Well, somatic support, if anything, only improves subsequent organ function. If the family were to choose that, that's certainly not a reason to persist. So I see all the reasons would be to wait. I see a little benefit in rushing towards this.
Very good.
Sonny, can I ask
Steve
you a question?
has...
In the context of this guy obviously has a severe traumatic brain injury from the gunshot wound, but do we argue that a bad brain injury became a fatal injury after anoxic injury from a cardiac arrest? And if it's prognostication after anoxia, do we have to wait even longer?
Matt?
Well, per the guidelines, we'd have to wait 24 hours. But I agree, there's a lot of data that say that waiting longer is going to improve your neuroprognostication. But as the scenario Sonny was painting, where there was a clearly devastating injury prior to the arrest, I mean, I think that a 24-hour waiting time would be appropriate here.
Good. Okay, one last question. A 53-year-old man with catastrophic brainstem hemorrhage. He meets all clinical criteria for brain death. So it's a brainstem hemorrhage. I'll focus on that. No apparent confounders. Determined by 2 neurointensivists. Family agrees to donation. The bedside nurse calls 12 hours after the formal declaration, reporting some unilateral extensive posturing in the right arm and possibly a cough during a suction. Andrew, I'll start with you. How often when you hear this story do you suspect that it's actually a confounder, though that's not how everyone did the declarations with the thought that there's no confounder?
So I think that's the first question you have to answer. I think it's really rare for it to be true that it truly was that the declaration was made, in the presence of a confounder. In our experience in Ontario, I think that circumstance arises incredibly rarely. And often there's a conversation before it happens because there's doubt about those confounders. So I think, in many ways, I'm almost always reassured by the fact that the process has often been followed to that point. That being said, I think, when you get that call, the first question you have to ask is you have to go back and ask yourself, were there confounders present? You have to go and examine the patient and see the movement for yourself. I don't think you can do that remotely or trust someone else's description. And then I think you may have to repeat your clinical examination in its entirety, depending on what you find. We certainly get this call, but most times it turns out to be an automatism or spontaneous reflexive movement after the determination of death.
So Matt, you probably take these calls as well. How do you manage the anxiety, distress on the people on the other side of the phone call who want to kind of step away from donation then?
Yeah, I think, Andrew made some great points, and I think the first thing you got to do is just kind of walk everybody back and make sure the facts have been collected appropriately, and make sure that the situation is clear and that you're making decisions based on the best information you can gather. And at the end of the day, if after, as Andrew suggested, you've gone over, there are no apparent confounders, the exam remains ambiguous in terms of their maybe some complex spinal reflexes that, and they can be quite complex and difficult to exclude from some centrally mediated posturing. And at that point, an ancillary test would be appropriate, and that remains an option, although you want to leave that as the a last resort if possible. But it certainly is. This would be a situation where once everything has been reviewed appropriately, that this would be a legitimate reason to seek out an ancillary test.
So one last question then, that's a good answer. Maybe this is to anyone on the panel. It's been suggested in some of the provinces that started paid donation physicians that the second declaration was done specifically by the donation specialist who came from the ODO. And the thought was that they, over almost half the time, found an error in the initial declaration and felt that it improved quality in the declarations by having someone from the ODO do the second declaration. Do you think you'd endorse that? Maybe Andrew?
Nope. I think I did my own poll EV. I saw enough people going. I just took my own vote there. Yeah. I've heard that sort of data described. I'm not sure, like, the difference between finding an error and then revert, like the result being different. I think. I'd like to see that published, to be honest, because I find that does not speak to our clinical experience, and we've got a lot of it, and I don't think it speaks to any individual, like aside from that, maybe that area, it doesn't speak to anybody's individual experience. So it's so far beyond what I could accept as like what I materially see as an error. I mean, like, could the sodium been 161 instead of 159 at the time when the second physician examined as opposed to the first one? Maybe, but I would argue that the likelihood that there's an integrity problem there is very small. I'm not saying you shouldn't test it, but I don't think the way to test it is to have an ODO physician do it.
Any other comments before we close? David, you have one?
If I can just make a comment about the
Yeah.
case, I think you're missing the point. The patient was not brain dead.
Mm-hmm. Yeah,
And it was a misdiagnosis, and it was a primary brain stem hemorrhage.
that's right.
And we need to be extremely careful when it's something like that. This was my case, and I was wrong.
This is yeah, I guess what we were getting at.
We didn't
that-
talk about the case specifically.
Yeah. Yeah. Is that clear? Yeah. Sorry we had to rush through that one. Questions from the audience? We've got a couple of minutes for the panel. I think we're out of time. If you bear with me, there's one more question which you guys are answering. A couple of plugs. We've talked a lot about the neurologic determination of death today. Amanda Van Bainham and Andrew Healy have put together a survey which should be coming out in the near future. I think it would be great if you're an intensive care physician here in Canada to respond to that and answer as quickly as you can, because I think it'll help us look at practice. As far as research, the Canadian Donation and Transplant Research Program has new grants that are coming out this month. So if you have an idea to research blood flow in the brain, do that. CBS has a booth that at 5 p.m. is going to demonstrate the new education platform for NDD. It's a really remarkable thing that was highlighted earlier in the day. And lastly, if you enjoyed the discussion, this is what the Canadian Donation Physician Network does on a monthly basis on our webinars. So if you want to find out more, there's also a booth, and we're happy to have you join. So thank you very much to all our panelists. I think give them a warm round of applause. Thank you.